Hello and welcome everyone. Today we'll be discussing the paper that has been published in this week. So the first paper is on optimal drainage time for evacuation of chronic subdural hematoma. This is a multicentric randomized trial for non-inferiority done in Denmark. Post-op drainage reduces the risk of recurrence of chronic SDH, but the optimal drainage duration is uncertain. The study aimed to identify the shortage drainage time without increasing the hematoma recurrence rates. It was a randomized, multi-arm, multi-staged, non-inferiority trial conducted at 4 neurosurgery centers in Denmark. Adults with symptomatic SDH were enrolled. Standard treatment involved a burr hole surgery. Patients were randomly assigned to 6-hour, 12-hour, and 24 hours post-op passive subdural drainage. The primary outcome was symptomatic hematoma recurrence at 3 months post-surgery. The non-inferiority margin here was 7. Coming to the results, 347 patients were enrolled and 331 followed up in the 3 months. 105 patients were assigned to the 6-hour group, 111 to 12 hours, 115 to 24 hours. Patient demographic was 25% women and 75 men, with a mean age of 75.7, with a median MRS of 4 and median GCS of 15. The hematoma recurrence at 3 months showed for 6 hours it was 27%, 12 hours 22%, and 24 hours 10%. The increased risk of hematoma recurrence 6 hours was plus 16.5 percentage points. For 12 versus 24 was 9 percentage points. So non-inferiority of 6 to 12 hour drainage compared to 24 hours was not established. Mortality at 3 months, that is 6 hours, was 7 deaths, 12 was 8 deaths, and 24 5 deaths. So the common complications post-operative was infection, and the source was urinary tract, which was also similar in the groups. So the interpretation is shorter drainage time resulted in higher recurrence rates compared to a 24-hour drainage. The study supports 24-hour drainage as a standard practice for post-operative chronic subdural hematoma. Further international trials can be needed to generalize these findings in other patient groups. The next is tenecteplase versus alteplase for thrombolysis of patients selected to use perfusion imaging within 4.5 hours of ischemia. This was again a multicentric randomized trial. The background here is intravenous tenecteplase has shown potential advantages over alteplase in this particular group, and the study aimed to determine the non-inferiority of the drug. The methods used was it's a multicentric international open label parallel group randomized non-inferiority trial, 35 hospitals across 8 countries. The enrolled patients aged more than 18 years within 4.5 hours of ischemic stroke. And the patients were randomly assigned to tenecteplase or alteplase via web server, and the primary outcome was the proportion of the patients without disability, that is a modified Rankin of 0 to 1 at 3 months. So in this, the primary outcome showed there was no much difference between the two groups. The disability was similar. The primary outcome in terms of the per protocol analysis also was similar. Symptomatic intracranial hemorrhage was 3% versus 2%, and mortality was 7% in tenecteplase versus 4%. So the interpretation here is the study supports the non-inferiority of the tenecteplase to alteplase in especially with perfusion imaging for selected group of patients. The non-inferiority has confirmed in per protocol analysis also, but not in the intention to treat analysis, possibly because of the small sample size. The trial demonstrates the feasibility of using perfusion CT for patient selection in early thrombolysis. The next is low dose morphine to relieve dyspnea. And the background here is morphine is known to relieve dyspnea in various clinical setups. The efficacy and the safety of low dose over here in ICU patients with acute respiratory failure is being analyzed. It's a single center double blind phase 2 randomized trial run in France. Non-intubated adults with severe dyspnea admitted for acute respiratory failure were included. Patients were randomly assigned to receive either low dose morphine or a placebo, and the primary outcome was average dyspnea over the next 24 hours. Secondary outcome including dyspnea at different levels, anxiety, respiratory rate, and intubation rates. So in the results, 22 patients were randomized. No significant difference in the average dyspnea was found between the two groups. In the secondary outcome, morphine showed lower dyspnea scores immediately after titration and 4 hours later, and higher cumulative possibility of intubation in the morphine group. The adverse effects seen were higher intubation rates with the morphine group, no significant difference in the adverse effect related to nausea and constipation. So in conclusion, low dose morphine did not improve the average 24-hour dyspnea but had a significant immediate effect, and increased risk of intubation was observed with morphine use. So we need future trials to see whether this initial dyspnea reduction is important and whether we want to use morphine in this group of patients. The next is high flow nasal oxygen with non-invasive ventilation. The background here is the study aimed to compare HFNC with NIV in acute respiratory exacerbation with COPD, and the method used was a randomized open label non-inferiority again conducted in large tertiary academic center of 2 ICUs from March 18 to 22, and patients with ACOPD with baseline blood pH of 7.25 to 7.35 with PCO2 more than 50 were included. Patients were randomly assigned into the two groups, and primary endpoint was treatment failure, which was defined as intubation or switch to other treatment. Secondary outcome was intubation rate, treatment changes, blood gas analysis. And in this, the results show that 225 patients were included, 113 in HFNC, 112 in the NIV. The primary endpoint showed that HFNC had a failure rate of 25.7, NIV had 14.3. So the risk difference was 11.38, which was exceeding the non-inferiority threshold of 9 and was statistically significant. The secondary endpoint showed high intubation rates with HFNC and no significant difference in the ICU length of stay or mortality. ABG was similar, and PCO2 was significantly lower with NIV. Patient comfort was better with HFNC, but the conclusion that we draw is HFNC is not shown to be non-inferior and NIV is clearly superior over here. NIV is more effective in PCO2 reduction, in lowering the intubation rates. SFNC, though associated with patient comfort and fewer nursing intervention, did not really give much benefit. Further studies are needed to explore if any population can be given where HFNC can be still tried. Finally, the study was lipid intensive drug therapy for sepsis. It's a phase 2 clinical trial. The background here is sepsis is a condition associated with morbidity and mortality. Low cholesterol level in sepsis correlates with worse outcomes. The trial aimed to assess if intravenous lipid infusion could stabilize and increase the cholesterol level in septic patients. It was a phase 2 adaptive randomized pilot clinical trial conducted in emergency department or ICUs of an academic medical center. Enrolled septic patients within the first 24 hours of recognition of a SOFA more than 4 or shock. Patients with low cholesterol were randomized to receive one of the 3 doses of lipid emulsion and no drug. The endpoint was serum total cholesterol from enrollment at 48 hours. The secondary endpoint were the various lipid parameters, SOFA score and 20-day mortality. In this, they enrolled 49 patients. 47 completed the trial, 24 in control, 23 in lipid. Primary outcome showed no difference. Lipid emulsion group, a mean change of 5 was seen. Control group, a mean change of 2 was seen. Secondary outcomes was similar changes in the various lipid profile parameters. Triglyceride was elevated in lipid emulsion, which was significant. 48 hours so far, more importantly, the clinical parameters were not significantly affected. Adverse effects, that is lipid emulsion, had 5 serious adverse effects, including deaths due to septic shock and cardiogenic shock. Control group had 12 severe adverse effects, including intubation, hypotension, cardiac arrest, and death due to septic shock. So the conclusion that we can draw is IV lipid emulsion did not stabilize or increase the cholesterol levels in early septic patients. There is no significant improvement in the secondary outcomes like the clinical outcomes of SOFA and 28-day mortality, and we need further trials to see whether we can explore this therapy in some subpopulation. Thank you for your patience.